my pleasure to invite Dr. Mount to speak today. Let me tell you about Dr. Mount. And I got to get my computer here. Okay, well, Dr. Mount is completed a residency at Toronto General Hospital and a nephrology fellowship at Brigham and Women's Hospital, where he is a chief and clinical chief in the renal division and director in the renal division of dialysis services. He is a member of the renal division at VA Boston and a Harvard Medical School faculty member. He is a research focus on molecular physiology of renal urate transport. Well, I am so excited to have you, Dr. Mount, today because you're going to talk to us about gout, which I have to say is not fun. I've had it and thought I broke my ankle. So welcome to Hope Week, Dr. Mount.
Thank you for inviting me. Can you hear me and see my slides?
And we can. You are good.
All right, good. So first off, I have some disclosures. I do consultancy in this area for Horizon Pharma, Alnylam Pharmaceuticals, and Alina Pharmaceuticals. The only relevant one there is Horizon Pharma that makes Pegloticase, about which I'll talk. So I wanted to just go over a few things that are relevant to nephrology and gout. Talk a little bit about the renal role in hyperuricemia and gout. We'll talk about some of the clinical features of gout. It's an inflammatory arthritis that also leads to tophi and joint destruction. And as we'll talk about, there are a lot of associated comorbidities, including chronic kidney disease. I'll talk a little bit about the inflammatory pathophysiology of acute gout and how colchicine and other treatment options modulate that. And we'll end up talking about urate lowering therapy as relevant to chronic kidney disease. So if you look at the annual incidence of gout as a function of serum uric acid, this picture is really important because it shows this inflection point at a serum uric acid of about 8 to 8.9, at which you start to get a high annual incidence of gout. But it's not absolute. So even if you have a uric acid of 12, you may not have a gout attack, but your yearly risk of that is maybe 7 or 8%. And it underlines the fact that uric acid or urate, and specifically monosodium urate crystals, are really the major mediator of acute gouty arthritis. We'll talk about some physiology, given that this is an area that I actually work in. And if you remember your proximal tubule, that's where a lot of solutes like phosphate and sulfate and bicarbonate and so on are reabsorbed from the filtrate and the glomerulus. This looks a little complicated, but basically there are two pathways. There's a reabsorptive pathway, where if you look at the tubule lumen up here, urate is filtered and then reabsorbed across the cell. There's this sodium-dependent anion transporter that loads the cell with anions like lactate and nicotinate, and those drive urate exchangers called URAT1 and O10 that reabsorb uric acid at the apical membrane. And then urate exits the cell at the basolateral membrane through a transporter that I work on called GLUT9. So why is this clinically relevant? Well, a lot of these anions that are reabsorbed with uric acid, if you increase the level in the blood, you actually get hyperuricemia. So pyrazinoate is the active metabolite of pyrazinamide that's used for TB. It causes very significant hyperuricemia. We've known for a century that if you infuse subjects with lactic acid, you see an increase in uric acid. In the ketoacid phase of diabetic ketoacidosis, there's an increase in serum uric acid that then responds to treatment with insulin. If you put people on high-dose nicotinate or niacin therapy for hypercholesterolemia, you'll see an increase in uric acid. And ages ago, when we used to use high doses of aspirin for arthritis, you would see that was uricosuric and uric acid went down, whereas the low-dose aspirins that we give is another anion that gets exchanged, and so that's associated with an increase in serum uric acid. Just a fun sort of very old paper from 1962 that looked at uric acid as a function of acute alcoholism and alcohol toxicity. Many of you may know that alcohol is a risk factor for gout. largely because it increases serum uric acid through this same kind of physiology. So these were patients coming in to Boston City Hospital with acute alcohol intoxication, and all of them had very high uric acid, or certainly higher uric acids than when they were in the hospital for a few days. They took some, at that time, Harvard medical students and made them drunk with oral alcohol. And you can see as the serum alcohol went up, blood lactate went up and serum uric acid went up with a reduction in uric acid clearance. So this is part of, uric acid is always under dynamic flux, the way it's handled by the kidney. And that depends on, what other anions are around and also what the physiology is for that given subject. But this is what we call trans-stimulation. So you have an increase in the filtered amount of these anions that stimulates apical urate uptake. However, these same anions, if at higher concentrations, can actually compete with urate for exchange, and then you have actually a reduction in uric acid. So it's a complicated physiology, but it's clinically relevant. There is, at the same time, a parallel pathway of secretory transporters, but reabsorption predominates over secretion in the kidney, so that the fractional excretion of urate is about 10% in normal subjects. So that means most, 90% of filtered uric acid is reabsorbed by the proximal tubule, and that's a large part of why patients get hyperuricemia and gout, because there's an overactivation of that reabsorption. And also, there are a lot of different hormonal regulators. If you put people on a high salt diet, uric acid actually goes down, whereas if you put them on a very low salt diet, uric acid goes up by a substantial amount. And we see this in the clinic. People that are volume depleted and come in with pre-renal physiology will have a high uric acid. Insulin plays a big role in regulating uric acid. I just had a paper that came out on that, and that's a big role, factor in why metabolic syndrome and being overweight and having insulin resistance is associated with high uric acid. And there are many other hormones listed here that regulate uric acid. So enough with the physiology. If we think of the epidemiology of gout and the comorbidities, this is an extremely common problem. So almost 10 million people probably at this point in the US have gout. 71% of those patients are hypertensive, 56% are obese, 26% have diabetes. And this goes with that insulin story and the hyperinsulinemia. This is a key part of the metabolic syndrome is hyperuricemia. About 24% suffer from kidney stones. We won't talk about that, but that's actually related to an acidification defect where uric acid gets crystallized in the kidney and you get stones. The key point, though, that I think is really important to emphasize to everybody is about 71% of American gout patients have at least CKD, have greater than CKD2. So they have GFRs less than 60. And even more importantly, around 20% will have CKD4, so GFRs less than 30. So that's about 16% of men with gout have CKD4, 31% of women. So what is gout? Well, typically it occurs due to crystallization of monosodium urate in peripheral joints with lower tissue pH and lower temperature. And classically, this occurs in the first MTP joint, which we call podagra. So this, the red hot big toe that everybody knows as being a cause of, a big symptom of gout. The differential diagnosis can include pseudogout, where there are other crystals that crystallize in the joint. But generally, somebody who's hyperuricemic with the relative risk factors, you can pretty much assume that this is gout, or what we call, likely gout or presumptive gout, if they've had episodes of podagra. Typically, this is self-limiting with a resolution in 1 to 2 weeks, but it's very painful, as anybody who's had gout can testify. And this disorder sort of spreads over years. If you look, there are patients that have asymptomatic hyperuricemia. They may have some degree of subclinical tophi, but they only get gout at a certain threshold of monosodium urate within the body. And they'll initially get acute attacks of gout with intracritical periods, and these attacks get worse and become more frequent. And then with advanced gout, you have chronic pain and chronic joint destruction that progresses badly over years. So these are the pictures of gouty tophi. These are neutrophils surrounding monosodium uric acid crystals with what are called extracellular traps. And these deposit in areas with low temperature and high and low pH. So you'll see them in the hands, you'll see them at the elbows. And more frequently now, rheumatologists will look at these joints and find tophi with joint ultrasounds, as I'll show. What we want to prevent is this, the bony erosions that you see in advanced gout and the chronic arthropathy that occurs with advanced gout. So this is really a key point. This isn't just a nuisance disorder. This causes joint destruction over the years if you have bad periarticular tophi in particular. So how do we diagnose it? Well, the gold standard is to aspirate a joint and look under the microscope with a plain polarized light. And these are what are called negatively birefringent crystals that are yellow when aligned parallel to the axis of the compensator and blue when aligned across the direction of polarization. So ideally, an orthopedic surgeon or a rheumatologist taps a joint. It's pretty difficult to do that in the first MTP. So it's usually bigger joints like the knee where they'll do an aspiration and have the lab look for uric acid crystals. One interesting thing is because of inflammatory cytokines, during an acute flare, uric acid actually drops because you get an acute uricasuria. So sometimes people even have a relatively normal uric acid during acute attacks. The other, increasingly, we're relying on rheumatologists to do bedside joint ultrasounds to make a diagnosis of gout. This is what's called the double contour sign in the first MTP joint, where you can see two sides of the synovium there because of hyperechoic enhancement by monosodium uric acid crystals. And they will also use joint ultrasound to look for periarticular tophi. I always send my patients who I think have gout to a rheumatologist at least once to get their blessing that this is indeed gout. And I quickly zeroed in on the Brigham rheumatologist that does joint ultrasounds. And he's the one that I send all my patients to so that he, get his blessing as to whether he thinks this patient does indeed have gout. More recently, there's this stunning modality called dual energy CT. To my understanding, it actually looks at sodium levels and sodium crystallization. And this monosodium urate, if they gate it right, shows up as these green deposits. And it's a really dramatic demonstration of just where you see tophi and monosodium urate in gout. So you can see it here in this patient's wrist joint. You can see the tophi around their finger joints, and you can also see the tophi around their first MTPs. And there's been a lot of interest in the other sort of symptoms of gout. You can see monosodium urate crystals around the spine, and patients with gout can also get back pain. In terms of inflammation, monosodium urate is the key inflammatory stimulus, as we'll talk about, but it turns on the cytokine interleukin-1 beta. And these crystals initiate inflammation through what's called the NLRP3 inflammasome, which is a complex mix of different proteins. And you get this crescendo-decrescendo pattern with resolution in part through formation of what are called neutrophil extracellular traps that also lead to tophi. So schematically, you have hyperuricemia, then you get deposition of monosodium urate crystals that turns on the inflammasome, particularly in the presence of fatty acids that turn on toll-like receptors. And the end result is you turn on caspase, which is this big enzymatic complex that converts pro-interleukin-1 beta to interleukin-1 beta, which goes on to cause the inflammatory and febrile response even. This can then get resolved by these aggregated nets, and then you can end up with inflammatory aggregated, non-inflammatory aggregated nets for tophi, these deposits of monosodium urate. In terms of where we can intervene pharmacologically, it's important to notice that colchicine inhibits the NLRP inflammasome, and we now have a lot of IL-1 inhibitors, for example, canakinumab, which is a trap antibody from Regeneron, if I remember, and anakinra, which is an IL-1 receptor antagonist. Okay, going back to gout and CKD. As I mentioned, there are about 9 million patients with gout in the US. There is some evidence that CKD or reduced GFR tends to worsen gout. So early onset of tophi or a higher tophi burden seems to correlate with reduced GFR. Hyperuricemia also associates with CKD and with progression of CKD. And Rick Johnson and other people have been major proponents of this. You see an association with high uric acid and progression of CKD. The problem is this a chicken or the egg phenomenon? And randomized controlled trials that came out last year demonstrate no renal benefit for giving patients with renal disease uric acid lowering. And this has been, kind of a turnoff for the renal community because they'd heard that this was going to be, a new therapy for progressive CKD, but it really has sort of been a dead end. However, there is a significant amount of evidence that maybe gout itself will worsen progression of CKD. And that's a big research interest of mine. And it's separate from this issue of hyperuricemia, which is really a more proximal sort of finding with uric acid. The key point, though, at the bedside is that CKD complicates the management of gout for reasons that I'll go through in a few minutes. Additionally, there's a high prevalence, about 13% of gout in renal transplant patients, particularly those that were treated with cyclosporin A. So many of you that were around in that area remember these patients on cyclosporin with really severe sort of lobster claw tophaceous gout. Tacrolimus has a lower risk of hyperuricemia, but it also causes hyperuricemia, but nowhere near the same, with the same amount of sort of viciousness that cyclosporin does. So what are the treatment goals in gout? Well, for an acute flare, we try to terminate the acute attack as rapidly as possible. In patients without CKD, we'll use NSAIDs. We can use colchicine or we can use corticosteroids, either oral or intra-articular. We also protect against future attacks to reduce the chance of crystal-induced inflammation. The idea is also to decrease the chances of joint destruction and other long-term complications. There's also the sense that we need to treat hyperuricemia and prevent disease progression over time. And we want to have some degree of effort to correct the metabolic problem that leads to hyperuricemia by encouraging, better glycemic control, weight loss, and so on. And we try to lower the serum uric acid sufficiently to deplete the total body urate pool, as we'll talk about. So in terms of acute gout flares, NSAIDs in CKD patients, NSAIDs are contraindicated. So you can't tell your patient with CKD4 to take ibuprofen for several days. Generally, prednisone is utilized a lot in chronic kidney disease. It's about 0.5 mg per kilo per day for 2 to 5 days, depending on the response, with then a gradual taper to complete a 14-day course. There are different ways of doing it. Sometimes they're given a steroid mini pack, which is a shorter duration. Rheumatologists, particularly in the knee and bigger joints, can do a local injection of the involved joints and then avoid systemic steroids. There also are these IL-1 antagonists, canakinumab and anakinra are the two that are available in the US. There's an evolving literature, but it's not routine therapy. What's interesting, though, is that there's a lot of interest in using IL-1 antagonists in cardiovascular disease. And if you look at these huge trials of anti-inflammatory therapy, be it IL-1 antagonists or colchicine, you see a reduction in acute gout. My favorite, however, is colchicine for a number of reasons. I'm not a big fan of giving CKD patients a lot of systemic prednisone. The problem with colchicine is it needs to be started within 24 hours of a flare. So colchicine, if for those of us that grew up with using it many years ago, when we used colchicine, it was really pretty harsh for gout. You would give huge doses to the point that patients had severe diarrhea. But the AGREE trial in 2010 showed that really a lower dose was just as effective as the high dose with not as much side effects. So the FDA had started out saying that these older drugs, if you do a randomized controlled trial to prove that they actually work, will give you a 10-year period of exclusivity for drugs like colchicine. So that's what happened with colchicine. They did this trial. They showed that colchicine was very effective. The regimen is they take 2 tablets, and then an hour later they take a third, and it does work in terms of the acute flare. The other use of colchicine, as we'll talk about, is what's called flare prophylaxis during urate lowering therapy, or ULT. And in that setting, you take for several months a low dose of colchicine every day, and that reduces the risk of having an acute flare as you reduce uric acid. For whatever reason, if you bring uric acid down, you can also develop a flare. It's not just any kind of stimulus that increases uric acid. The problem with colchicine, as we'll talk about, there's a lot of drug-drug interactions, particularly with statins and particularly with cyclosporin A. You really cannot use colchicine in a patient on cyclosporin A. So usually what I do, I have a lot of gout patients that I see, particularly at the VA in Boston. I'll start, if I know they have gout and nobody's put them on urate lowering therapy, I'll start them on a low dose of colchicine and then tell them to start low dose allopurinol and continue that until I see the target uric acid. So I collaborated with the company that did the trial in 2010 for colchicine, and they looked at patients with renal dysfunction. And we knew that if you look here at the bottom line, the solid line is normal renal function, sorry. The patients that had CKD4 had much more, had a lower clearance of colchicine. Interestingly, patients with end-stage renal disease had a slightly higher clearance, probably because of maybe extra renal metabolism being turned on. And there are other drugs like that. For example, bumetanide, the metabolism actually goes up in chronic kidney disease. Regardless, the colchicine dose needs to be titrated to both the drugs that the patient is taking, but also to the GFR. So you can, in patients with CKD4, they can still take that acute 3-tablet therapy, but they shouldn't repeat it within 14 days. And that they should be on no more than 0.3 milligrams a day orally for flare prophylaxis. For end-stage renal disease on hemodialysis, even though we thought the metabolism was a lot better than with CKD4, we were more conservative and said 1 tablet of 0.6 milligrams for an acute flare, and again, don't repeat within 14 days. And they can be maintained on chronic therapy, 0.3 milligrams twice per week. So as long as you are aware of the other drugs that can interact, and as long as you use a low dose, I found it very, very benign to use colchicine. Very few patients that are on it, even for flare prophylaxis for months, have complained of diarrhea versus the higher dose where it's a major problem. In transplant patients, you should use colchicine with caution or not at all. In those that have CKD4 with renal hepatic dysfunction, or on cyclosporin or other interacting meds. If you use it with cyclosporin and other interacting meds, you really need to be careful and monitor symptoms and labs. And that includes particularly CPK if they're on a statin plus the colchicine. For those that are on tacrolimus, you can still use it, but again, relatively low doses, 1.5 milligrams every other day in patients that have CKD4 or 3B. So what about urate lowering therapy? Well, a key concept that I'll just briefly review is this concept of treat to target. And we know from the physical chemistry that monosodium urate crystals go into solution below a saturation level of 6.8 to 7.0 milligrams per deciliter. There's several lines of evidence that support a treatment goal for serum urate of less than 6.0, or for patients with tophi and severe tophaceous disease, even less than that, less than 5 or even less than 4 milligrams per deciliter. The evidence, there's not great randomized controlled trial evidence, but there is some. There was actually a nursing intervention trial that was published 2 years ago in Lancet. And the point of the trial was to show that with really aggressive nursing care and education of patients, you had better gout care. But they also got their patients to lower serum uric acid, and that led to less flares and better control of their gout. However, this treat to target is quite controversial. The American College of Physicians wrote this really annoying position paper about 4 years ago that said that you didn't need to treat to target. And that caused tremendous consternation in the gout community and rheumatology, where they've been trying for so many years to get people to accept this. And I think we've sort of put it behind us, but it's still been a lingering problem. The xanthine oxidase inhibitors are really the mainstay of urate lowering therapy. So those are allopurinol and febuxostat. But really, allopurinol is still the most common prescribed urate lowering therapy. The key problem with allopurinol is this issue of allopurinol hypersensitivity, which is very rare. Maybe I can't remember the percentage, like 0.1% or so, but the mortality in allopurinol hypersensitivity is considerable. These patients can get an erythematous rash of variable severity from benign to severe. And it's the severe ones that can include Stevens-Johnson syndrome and toxic epidermal, toxic epidermal necrolysis. That can include the systemic stress syndrome with acute kidney injury, eosinophilia, fever, and hepatitis. And if you've ever seen a patient with allopurinol hypersensitivity, it's not a trivial disorder, and these patients can die. The risk factors include a high starting dose of allopurinol, concurrent use of diuretics, chronic kidney disease, female sex, and older age. It's thought that the major instigator is actually oxypurinol, and oxypurinol levels go up in chronic kidney disease, which explains why that's a risk factor. There is, however, an immunological basis to this, and there's an HLA haplotype, Delta 580, B5801, which is a major risk factor in patients with Southeast Asian ancestry and in African Americans. So it's actually recommended in patients who are of Asian ancestry to do an HLA B5801 genotype before starting them on allopurinol. And in the ACR recommendations 2 years ago, we recommended that African Americans also be tested for that polymorphism. And this shows that, as a sort of starting dose overestimated GFR, the higher the ratio of dose to GFR, the higher the risk of developing allopurinol hypersensitivity. So CKD is a risk factor for allopurinol hypersensitivity. When that was previously reported back in 1984, the concern was that allopurinol and oxypurinol levels in CKD were the major risk factor. So they came up with guidelines based on creatinine clearance, and these are still put verbatim in all the drug dosing guidelines. So it's been sort of disproven since then that you get a higher risk of allopurinol hypersensitivity with higher dose. And really, it's the first 6 months of therapy that is the risk for allopurinol hypersensitivity. But if you use the recommended dosing for allopurinol in chronic kidney patients, only 20% will actually get to goal of a serum uric acid less than 6. So this really sort of has been a major impediment to managing gout patients with CKD. And now there have been many studies showing that you can use higher dose allopurinol, but you need to just start slowly and gradually increase it. But this is a big problem for me, for example, at the VA, where I'll have patients on 400 milligrams a day of allopurinol, and they get admitted for a heart failure exacerbation, and the intern tells my patient that I'm killing them with high dose allopurinol and reduces the dose, and then we see them 2 months later with a gout flare. So this has been a big impediment to controlling uric acid and gout in patients with CKD. In terms of other urate lowering therapy agents, uricosuric agents are essentially not used. Probenecid is a pretty weak uricosuric and it's not recommended or effective in chronic kidney disease. There have been newer agents that have come through, lesinurad and verinurad, but they turned out to be nephrotoxic because of a big burst of uric acid in the kidney. Febuxostat is the major alternative to allopurinol. Provided you use enough allopurinol, febuxostat is not necessarily better than allopurinol or more effective. There was concern about an increased cardiovascular risk for febuxostat versus allopurinol, but recent studies have sort of allayed those concerns. So now pegloticase is sort of the pendulum is swinging back that we can use it. The major utility is using it in patients that have had a rash to allopurinol because they don't cross-react. You can't use both febuxostat and allopurinol. They have competing mechanisms. So allopurinol inhibits the active site of the enzyme. Febuxostat inhibits the tunnel that leads into that active site. So they're mutually antagonistic. The other drug that's come on the market the last 10 years or so is called Pegloticase, and it's a pegylated uricase enzyme. We don't have uricase, whereas pigs and other mammals have uricase. And so they have much lower uric acid levels. And you basically get an infusion every 2 weeks with this drug. And I'll talk about it in a few minutes. In terms of using allopurinol in chronic kidney disease, you need to start slow at 50 to 100 milligrams a day. I always tell patients to stop the drug immediately and call me if they develop a rash. I follow the serum urate every visit and gradually increase the dose until serum uric acid is less than 6. I also follow the liver function tests and peripheral eosinophils, and I will usually co-administer low-dose colchicine. But if you think of how we manage patients with chronic kidney disease, you can see how the nephrologist and nephrology nursing can play a huge role in getting these patients to goal, because we see them more frequently than anybody else, and we're used to sort of following algorithms and titrating drugs based on what the PTH is and the vitamin D and so on. So I've advocated for greater involvement of nephrologists in managing gout in patients with CKD4. You don't always need to use probenecid, colchicine prophylaxis, sorry. This was a Japanese trial with febuxostat where they started at 10 milligrams for 4 weeks and then 20 for 4 and then 40 for until the end. But they had several groups, 3 groups. In one, they did this stepwise, slowly increasing the amount of febuxostat. In group B, they gave 40 milligrams right off the bat and gave it with colchicine. And in group C, they had febuxostat without giving colchicine. So this was a trial really of whether you needed colchicine for flare prophylaxis if you slowly increased the urate lowering therapy. So if you look at the number of percent of patients and the gout flares, the gout flares were very low in the patients that were on the low dose titration, the slow titration, or group B with colchicine. And predictably, the patients that did not have any kind of flare prophylaxis or did not go slow, in the first 12 weeks, they developed gout flares. Similarly, you could see gout flares in the patients that were on had no prophylaxis in the last 12 weeks, and the patients that were slowly increased on febuxostat did not get flares. So it's not obligatory necessarily to give patients colchicine as you start them on low-dose allopurinol. Generally, I do if I feel like they can tolerate it, but not everybody necessarily needs to be on flare prophylaxis as you start them on allopurinol. The other important issue is that you cannot use allopurinol with azathioprine. And so Immuran is completely, you can do it, but you use like 1/10 the dose of Immuran with the allopurinol. I've done it a few times for sarcoid patients. MMF, however, can be utilized with xanthine oxidase inhibitors and like allopurinol and febuxostat. So the same problem applies to febuxostat. This is related to inhibition of both enzymes, both drugs of the relevant pathways. What happens is you inhibit the metabolism of 6-MP, and then you have higher levels of 6-MP, and you get more white cell suppression on Immuran. So finally, pegloticase, as I said, is a recombinant uricase that's coupled to PEG, and it's administered by biweekly infusion in an infusion clinic. And it's FDA approved for the treatment of chronic gout in adult patients refractory to conventional therapy. It induces, as you'll see, a really marked hypouricemia. The big issue is the risk of infusion reactions and treatment resistance, and that's due to anti-PEG antibodies. So polyethylene glycol is all over the place. It's in lots of drugs and foods that we take. So people can be sensitized to polyethylene glycol. They're evolving strategies to avoid resistance by giving them, for example, MMF along with the pegloticase, and also to use serum uric acid response as an indicator of resistance or antibodies. So what they do is every time they get an infusion, they get a serum uric acid. If that uric acid has gone up, that means the patient is now resistant because of antibodies, and they don't give the drug to avoid a reaction. So this is the initial paper from now 10 years ago, and they divided into non-responders and responders. The non-responders actually did get a clinical benefit, but you can see over time, after several weeks, their uric acid went back to what it was at the beginning of therapy. And what they did during that trial was they continued the pegloticase. These days, if somebody developed a uric acid that went up to, say, 5 or 6 after the second dose, after the first dose, we would not continue pegloticase. So that makes the risk of reactions much lower. But you can see with pegloticase, the uric acid goes down from like 10 or so to almost unmeasurable. And it stays like that as long as the patients are on the infusion. What's really important is the effect on tophi. And so tophi really sort of melts away in patients that are on pegloticase. So if you see a patient with gout and chronic kidney disease who doesn't have a uric acid that's at goal or can't take allopurinol or febuxostat for whatever reason, you should really advocate for trying to get approval for pegloticase. It's expensive, several $1,000s a dose, but it is for now a very important agent in therapy. And I'm helping a lot of other drug companies develop new agents. Alnylam, for example, has an RNA inhibitor that will be injected twice a year to inhibit xanthine oxidase in the liver. So there are a lot of different therapies that will come down the pike that will be hopefully better and less expensive than pegloticase and have less of the toxicities of allopurinol. But this is another dramatic picture. This is dual energy CT pre and post pegloticase, and you can see how radiologically you get complete resolution of these monosodium urate tophi throughout the body. So the take-home points that I wanted to emphasize today, I just wanted to talk a little bit about the physiology of the kidney and urate homeostasis and how what your patients are eating or what's happening to them can regulate their serum uric acid acutely. The key point is that 20% of gout patients in the US have CKD4. I talked about the use of colchicine in acute gout and for flare prophylaxis on urate lowering therapy. And the key point is that allopurinol dose reductions per GFR are no longer recommended. You do need to start slow and watch carefully, particularly in the first 6 months for the development of allopurinol hypersensitivity. And we talked a bit about newer urate lowering therapy, including febuxostat and pegloticase. So I think we have 10 minutes for questions.
Thank you so much for the presentation. A couple of questions. I'm going to add this. Can you stop sharing, please?
Okay.
That'd be perfect. So I think one of the questions is, what are foods you should avoid when you're prone to gout?
We're getting in here. Stop sharing. Stop share. There it is.
Yes, we're all learning about Zoom, that's for sure. So what are some foods that you suggest your patients avoid?
Diet actually doesn't play an enormous, as big a role as we tend to think in terms of effects in gout. Um, yeah, if you sit on a beach in Florida and drink a lot of beer and eat shellfish, that's a key that's going to cause a flare. So purine rich foods include, shellfish are the big culprit, but dietary restriction of purines doesn't play a big role in managing gout. And surprisingly, there's a lot of work, and that my lab works on is, the genetic risks for hyperuricemia. And the genetic risks for hyperuricemia are actually probably overweigh the dietary influence on uric acid. So I would tend to be, clearly patients should not over imbibe alcohol. There's an interesting association with coffee intake, in that coffee seems to protect against gout. We recently showed in the lab that caffeine inhibits insulin-activated urate transport, so that may be part of the effect. But generally, we don't recommend aggressive purine restriction anymore for gout patients, except, stay away from the big culprit foods and try to avoid alcohol intake.
Well, and I remember once eating some shrimp and it started a flare. I mean, it was awful. It was right when I have my fourth transplant now, but it was, I was getting ready to go on dialysis. I was probably had a lot of uric acid, and I really thought I broke my ankle. What do you hear from your patients that come in? Like, is it just always pain, or is there other ways that could show that they have gout?
Bear in mind, I'm not a rheumatologist, so they don't come to me with their joint pain. But joint pain is the flare is the usual symptom. Some people have sort of chronic joint pains that I've seen, and then once you get into destructive arthritis that I showed, it's chronic pain.
You're exactly right. I went to the orthopedist and said, I broke my ankle. And he's like, no, I think you have gout. So yeah. I was put it on a prednisone regimen that I know it just makes you so hungry that I'm glad that there's other treatments available. So what are the best ways that patients can prevent getting gout other than not drinking a lot? Those are on dialysis aren't really, we can't. And I've often been reminded that gout's often called the rich man's disease. I don't know. Is there any truth to that?
Not really.
Okay, because it was
it is in the sense that. Yeah, the rich can afford more, I guess, more shellfish and more booze,
more alcohol,
but
more time to drink,
that,
right?
Not really. Yeah, and there is the New York Times did a great piece on this about a year ago, and sort of going through the stigma of the rich man's disease. The key thing is to find somebody that'll adequately treat you. And the number of patients that I see that have gout, where I get involved is I see them in clinic and they have a uric acid of 9. And, they've had gout flares. They've gone to the emergency room in the past and nobody put them on allopurinol, or they're on a token dose of allopurinol and that just needs to be increased. So my role as sort of a gout-friendly nephrologist is to usually just increase the allopurinol and get their uric acid less than 6. So the treat to target is what will keep these patients free of acute gout, and theoretically will help reduce the chronic joint damage down the road.
One point that you made that I think is really important is that I saw rheumatologists and they prescribed colchicine to me. And I actually checked with my doctors because I was taking tacrolimus. And you really have to be careful about these drug interactions. Don't take anything unless you check with your transplant team and nephrologist. Yeah. I think that's so important. Any final thoughts about people who, what they can look for to monitor that if they may be at risk for gout but don't have any pain? It would be their labs. Is that right?
Well, it'll be their labs, and if they have abnormal lumps or bumps, the tophi are usually at the bottom of the elbow. I'm probably not great at finding them all, and often when I send them to the rheumatologist, he'll find some by ultrasound. But I think, look at the labs, and if they have high uric acid and they have compatible symptoms, say, I get these weird pains in I have a Bartter syndrome patient who now had then chronic kidney disease and now got a transplant. And she had sort of like plantar fasciitis symptoms that when Derek looked at her ultrasound, he thought she had MSU crystals. So, there can be any kind of weird articular symptom. You should think about gout, and have a rheumatologist examine you, preferably by ultrasound, and have somebody treat you and get you under control.
We have a comment in the thread that their family elders recommend celery and broccoli. Does that just prevent you from drinking all the beer and eating all the shrimp?
No, there are a lot of Eureka Uric foods. The big one is cherry extract. Has Eureka Uric effects. And there are also a few Eureka Uric drugs. So losartan is Eureka Uric, for example. It inhibits URAT1 and a bunch of other urate transporters. So there are foods that do reduce uric acid. The big one, as I said, is cherry extract and cherries. And there are many others. I mean, it may not be caffeine in coffee. It may be some of the flavonoids in coffee that are Eureka Uric, and that's not very well characterized.
Well, I have to tell you, I am so grateful that you said coffee was okay, because everybody's talking about, I can't survive without a cup of coffee in the morning. So now I can be happy that I'm indulging in 1 or 2 cups. So
there you go.
Well, thank you, Dr. Mount. We appreciate your time, and I love that you love art. I love art, and thank you for your dedication to people who have kidney disease. We really appreciate it, and I personally appreciate nephrologists who specialize in something, because you really are the trailblazers to change care and provide better protocols for us. So, on behalf of patients, thank you for your time.
Thank you. Pleasure talking to you guys. Bye-bye.
Bye. And a shout out to our corporate mission partners for making this happen.